Hello, everyone. NextGen Healthcare is excited to welcome you to our session today on revenue cycle management with our guest speaker, Elizabeth Woodcock. So at this time, we're pleased to introduce our guest speaker, industry expert and author, Elizabeth Woodcock. Elizabeth's book, The Physician Billing Process, is an excellent companion guide to the subject matter that we'll be presenting today. So if you want a deeper dive, definitely consider getting a copy of the book. And again, that's the Physician Billing Process. I'll go ahead and turn it over to Elizabeth.
Thank you so much, Jonathan, for the great introduction. And thanks to NextGen Healthcare for sponsoring our webinar today. I'm so excited to be able to be here with you during your lunch hour or early afternoon or late morning. And most of all, thanks to all of y'all for taking the time out of your busy schedule to be learning more about best practices and revenue cycle management. I feel like, oh my gosh, the pandemic has been really at the top of all of our minds now for almost 18 months, and we kind of really haven't even thought about getting back into the routine. But we actually want to talk about today's topic and all important subject in, of course, running a healthcare organization today. But in light of what's been going on the last 18 months, we actually may have to change our optics just a little bit to jump right back into our revenue cycle management. So what I'm going to do now is go ahead and stop my video so that I'm not distracting you as we're talking through the slides. And I want to go ahead and start really kind of going over the narrative that is impacting revenue cycle management today. And of course, it has to do with the last 18 months and indeed the changes that we have seen because of the COVID-19 pandemic. We saw a massive dip in volume. This softening of volume, of course, had an enormous impact on us from a financial position. Fortunately, most healthcare organizations were able to receive some grants, subsidies, etc., through participation either at the federal or state level. But regardless, we definitely saw these volumes softening. But the story today, as we move into Q2 of 2021 and are on the brink of moving into Q3, is surge in demand. We're seeing practices with patients lined up, abandonment rates at our phone centers, our phone operations are reaching into the 30%. We're having a really tough time today, even keeping up with the significant demand. So this is obviously impacting us from a revenue cycle management perspective. After we had that little bit of a lull in Q2 of 2020, now we're back in full force. And what that means is our claims are back in full force as well. Now, we've been, if you will, spared a little bit in terms of the uninsured based on a number of changes that we had from a coverage perspective, which we'll talk about in just a second. But certainly the COVID pandemic has also resulted in increase of unemployed. And of course, the ripple down effect of that is an increase in the uninsured. And so we believe that the data shows us that employer-based coverage was lost between 2 and 3 million people. We're still waiting to see the results in terms of the percentage change in the uninsured for 2020, but it looks like that may have ticked up a little bit. And of course, the implications are strong in revenue cycle management in that everybody still needs health care. And so in your practices, of course, you're expected to be able to take care of these patients, but also need to be paid. Now, again, this was kind of interesting and I think actually has some fairly long-term implications as we think about the optics from the patient's perspective in 2020. Soon after the pandemic began, the family's first coronavirus response act was signed into law. And remarkably, despite the fact that the United States does not have a single payer system, the federal government was able to get pretty much all payers to agree. So your Blues, your Aetna, United, Cigna, to waive patient cost sharing, again, to waive patient cost sharing for any sort of COVID related services. Well, many of our payers also took another step and waived cost sharings like co-payments, for example, for services that were non COVID related. So there was a period of time from about mid April to early May through the fall, and for some payers, even through the end of the year, that we actually didn't charge patients their normal cost share. And so patients have kind of gotten used to that, right? I went to the doctor in 2020 and, oh, you didn't ask for my $50 copayment. Or I had a telemedicine visit and isn't that odd? I never got the bill for the $50 copayment. Now, in both of those cases, we may have forgotten about it, but in both of those cases, we also may have been contractually directed to not charge the patient. Regardless, you're never going to get a phone call in your billing office from a patient that says, "Oh, Joe, did you know what? I had a visit a couple of months ago. Y'all never charge me. Do you think you're going to send the bill? Because I'm happy to pay." That phone call isn't coming through. And so here we are in June 2021, where we've had almost 18 months now where some of our payers haven't extended patient cost sharing for COVID related services, and others have even extended that policy for non COVID related services. Our patients got used to not paying. And so, indeed, making sure that you know the policies for your own payers and that you have in place in your own practices or healthcare organizations workflow to reimpose cost sharing is absolutely crucial. That is going to require some education in terms of patients. I think it also is going to require transparency so that we're able to explain this up front. It is made more difficult by the workflow changes that were made almost overnight in 2020, where due to COVID related requirements and or our concern out of patient safety, we began to put in place contactless registration processes. Now, I'm a big fan of this, so don't think that I want to go back to the traditional front desk clipboard type scenario. But what I do need to say is that how has this impacted revenue cycle management? And as you well know, oftentimes we have a bifurcation between our operations team and our finance or revenue cycles management team. And so, what I'm encouraging you to do is to take those two silos and to come together and to talk about, okay, if we're going to continue this contactless registration process into the future, which makes a ton of sense from a patient experience, from an operations perspective, in terms of our efficiency, staffing, et cetera, et cetera. But where we're going to collect the copayment. Because if we do it all on the back end, folks, we are going to slide backwards so fast as it relates to our financial position. You're going to be in a world of hurt. So, making sure, again, that we recognize the implication on workflow. We know that it's been incredibly frustrating to follow all of the payment issues related to the virtual services that we've been providing. So we often call these quote unquote telemedicine. Interestingly enough, telemedicine actually has a very specific definition. And I don't want to go down that rabbit hole, but what I do want to make sure we recognize is we put on our radar screen all of the regulatory issues that we have at play in terms of the federal government. We also need to pay careful attention to the state government. And the reason we need to do that is because the practice of medicine is licensed at the state level. So, if we're trying to provide care to patients across state lines, or we want our doctor to provide a virtual service while he or she is at the beach and it's across state lines, then indeed we've got to continue to pay careful attention to these regulatory issues. The most important of which, in my opinion, is the public health emergency. And the reason I say that is because the PHE basically means that the government can put pause onto all of the strict requirements related to telemedicine. What we do know, and I actually just logged on a few minutes before our webinar, hoping that this PHE would have been extended. The last time it was 90 days as of April 15th. But if you look at your clocks, of course, or your calendars, you know that we were actually only weeks away from this public health emergency being over. Now, the good news is that earlier in the year, very soon after Biden took office, his administration sent this memorandum to all of the governors of the states. So this is in writing. This is a copy of that letter. I've just taken a screenshot of it. And indeed, what we can see is that last line: to assure you of our commitment to the ongoing response, we have determined that the public health emergency will likely remain in play for the entirety of 2021 ... And so I think that's really good news, but it also means that, okay, well, what's next, right? As we start thinking about our revenue cycle management processes and systems, we also have to pay careful attention to the what's next in terms of virtual care. Depending on your specialty, you may be considering as much as 100% of the services you will be continuing to provide virtually. Or, of course, for some specialties, you may just be considering 0 to 5%. But regardless, again, it's not just an operational issue. We, from a revenue cycle management perspective, must really stay on top of these issues as they continue to change the paradigm of the healthcare reimbursement landscape in the US. Speaking of landscape, what may be actually the most lasting implication of the pandemic is the fact that traditional healthcare systems have been completely disrupted. Okay, I know. And in fact, I live just blocks from one of the CVS Minute clinics here in my home city of Atlanta. But indeed, we've had a few of these, little minute clinics and kind of, I'll call it some street corner retail based clinics. But oh my gosh, the pandemic basically blew up the healthcare system, at least on the ambulatory setting. We have on the left side of the screen 5 of the many hundreds of privately held but very well funded startups or mid sized companies that are disrupting the healthcare system. And of course, on the right side, we have some of the publicly traded companies that are doing the same, but have even more dollars behind them. And so, why would I have, for example, Cigna up here? If you are a Cigna beneficiary today, just like United, Aetna, and many others, you can go on to the Cigna wholly owned telemedicine company and for free, get a virtual visit. If you are a Cigna beneficiary and you want to go see your own doctor, there's a copayment, but not if you log on to Cigna's website and go see their doctor on their telemedicine company's website. So I could go on and on about these disruptions, but I will say that for all of us who are out there going, oh, the pandemic's almost over, or it is over, we're going to go back to revenue cycle management as it were pre 2020. Folks, it ain't happening. It ain't happening for all these reasons. And I'm sure you can throw in a few more. Change is on the horizon. What we do know is now is the opportunity to stop complaining, stop thinking about, oh, the pre 2020, I wish it could go back that way. Now is the opportunity to get it right. We know our workflow has changed fundamentally. We know the regulations are changing and will continue to change. We know that our competitive landscape will never be the same again. We have to have a lens into revenue cycle management today for our practices, for our healthcare organizations, for us to be able to sustain the healthy financial position in order to serve the communities that we do for the long term. So let's talk about how. Let's talk about creating an action plan. And this, in and of itself, is something I would actually like to convey to you. Now, you may be representing an imaging center, a family practice office, a physical therapy practice, a large multi specialty practice or organization, a hospital employed practice. I mean, wow, there's so many different settings that we all represent. And so, not all of these will have relevance to your practice, to your specialty, or maybe to one of the sites that you represent. But what I want you to do is to proactively start thinking about change, thinking about the action plan. It's incredibly easy, particularly with the staffing crisis that we have on hand. We simply cannot even find enough people to work for us to really just say, the only thing I have to do now is get through the day. But I am urging you to create that action plan to plan for the future because I hope I've made a compelling case that our world and revenue cycle management will actually never, ever be the same as it was pre 2020. So let's talk about our 5 best practices, as you can see listed here, from recognizing the domino effect to managing receivables. And then we'll be sure to throw in another 5 bonus best practices before we move into the Q&A period. I learned very early on when I started in billing and collections, which now was 25 years ago, when we could send in a claim and ask for a charge, and we got paid a percentage of that charge. Boy, were those the days. But even then, we knew the mantra for revenue cycle management was garbage in and garbage out. And so it pays for us to think about this narrative that the domino effect still exists. When we do something wrong, when we collect the incorrect data, and of course, as you can see, well, we don't often see it any longer, but the CMS 1500 claim form has more than 30 fields on it. If we even get one of those, not even fields wrong, but characters wrong, we get a denial. It takes us some time to actually look at that denial. We have to sort through our work queues. It has to come to, let's call her Betty's attention. And by the time it gets to Betty's attention, right, we look and we see, oh, hmm, maybe we have on file a card for that patient. And sure enough, we do. Unfortunately, it looks like, however, that our front office staff didn't get a current card. So we might have Miss old card, but we don't have the new one. And in fact, that's where the whole problem stemmed from. So let's go ahead and prepare a statement for the patient because we'll transfer all those charges to the patient. And surely the patient will call the day they get it. Well, as you and I both know, that takes another few weeks, if not a few months. And after all said and done, it's a good old 90 days between when our one very simple mistake actually gets resolved. And at that point, of course, as we know, now we're bumping into timely filing deadlines at the correct payer. Now, we could ideally appeal that because we did indeed submit in a timely manner the first one. But before we kind of go down that route, we have to recognize that that cost us people, that cost us time to make up for these mistakes. It pays to do it right the first time around. And so we need to not only have an amazing eligibility process, financial clearance, whatever you want to call it within your organization, but there are really two things that I want to mention here. And the first is what happens when there's an exception. And I say that because everyone has eligibility processes in place now. Every single organization does. I haven't been or talked to an organization in almost 2 years that doesn't have a really, really good process in place. And oftentimes, of course, that's been set in place, that's been established by the revenue cycle team. But what we don't always have is how to handle exceptions. I've been in too many practices where I'm sitting behind the employee as he or she is registering patients and the screen is flashing. I see red lights coming on. I see all kinds of colors and X's and all kinds of stuff happening on the screen. And indeed, I was at a practice where I pointed that out to the employee. And sure enough, he said, oh, Miss Woodcock, I'm not really sure why it's flashing, but what I can tell you is if you go up to the top right hand corner and you hit that white X, it all goes away. It all goes away. And of course, as you know, he or she just ignored the alert. My point is that don't just set and play the process. Make sure that you hold your team accountable for when the process gives you an exception, an alert. And that's going to happen at least 5% of the time, if not more. This is something that I would encourage you to actually have as a data point for your own organization is what is our eligibility error? And then you want to report back how many times eligibility errors slip through the system, not just for patients who are seen face to face, but remember, we have to start building this workflow for our telemedicine and our virtual care like remote patient monitoring. Right? We have to have eligibility in play for those services as well. Of course, we also have to have it for our physicians when they go to the office, nursing home, dialysis center, et cetera. The point is making sure that eligibility processes are not only established, but you hold your team accountable for accuracy and timeliness. Furthermore, integration of looking at not only do we have an exception, but we have tools in place to help us find the correct patient's coverage. And this is often called an insurance sweep or an insurance coverage sweep. But again, really thinking about bringing in the automation, the tools, the resources to make sure that our eligibility process is supporting our revenue cycle management outcomes. Now, as I mentioned before, if we're always there saying, well, it's okay if Jose, for example, at the front office, if he doesn't get this accurate, because what we do know is that Bhavna back in the business office, she'll always fix it. I don't know about y'all, but I haven't been to a healthcare organization in more than 20 years that has not enough work to do. You've got more work than you have people to do it. So this is a staff resourcing issue in addition to a cash flow. We do know that just reworking a denied claim cost you about $15, and you may want to apply that number in some sort of internal analyses as you really start to hone in on making sure that the front end, again, the process is not just in place, but we're holding our team accountable. The other big ripple effect, of course, is that whenever we get it wrong and we have to restart back with another payer. So, for example, I gave you the Cigna, and maybe that patient was actually United and we just missed it. One of the things that I think we don't always recognize is that our aging actually on all of our reports, as well as what we do in terms of work queues, et cetera, all returns back to zero. That's sort of a function when you think about it of our billing system, right? Because it's going back through the stages of collections, right? Because now it's found a payer. It went from Cigna to United. And so when it goes to United, now it gets, spits out the claim. You guys know the rest of the story. But what's fascinating is that we forget that when that claim is re-aged, when we correct the problem, the probability of payment is negatively affected. And so I want to make sure that we really, as we sit down with our team and review our reports, if we have a big problem, our age trial balance actually is not reflecting reality. Because if I'm just spinning accounts back because I have all these errors and it's re-aging them back to zero, then I'm actually going to look like I have a pretty good age trial balance. And the reality is, I have a pretty bad cash flow situation. So I always like to run reports for my H trial balance, not only by what the default in the system is, but also by date of service. And that gives me a really good perspective about this challenge of re-aging. The other thing I wanted to point out is payment plans. We do know that more and more patients are asking for payment plans, and we actually have a fair amount of really nice technology and automation to support us in this process. The problem is that we have agreed to age those receivables. And when we do that, we need to make sure that we have that reflected on our reports to include our age trial balance. Because as you can imagine, we're going to have payment plans that are over 150 days or 120 days. And we've actually obligated ourselves to them by signing off on the payment plan. So what I like to do is to create a separate financial category or a subcategory for payment plans and report those separately on my H trial balance. And again, they really actually need to be excluded from my H trial balance and possibly from my days and receivables outstanding reports because I have agreed to age them. They're not a bad thing, it's a good thing, but I can't just jumble this all together and expect to really have the business intelligence that I need from a reporting perspective. Now, speaking of patient receivables, we certainly need to, if we haven't before, strengthen our collections process. And that does include rethinking our cycle, particularly if it is 180, 360 days out. We've got to really think about this cycle as from the patient's perspective, right? If you get a bill that's a year old, Like, how likely are you to pay that? No, you're not going to pay it. Yeah, the patient is back on the tennis court. They had probably their service not just a year ago, but probably more like 15 months ago. Because again, it's all back to that timing issue. So we want to make sure that the statement is sent out when it's due or at checkout. And remember, when it's due is quite often 45 to 60 days behind the actual date of service. So maybe that should make you feel a little bit better because we're actually giving patients more than 90 days because their service was done at T minus 45, for example. So I don't want to go into all the details, but I would really urge you to think about a 90-day cycle because that aligns with patients' probability of payment. And if you want to actually have a quote unquote longer cycle, instead of making it longer in time, actually make it longer in touch points. And in fact, my recommendation is to think about twice or bi monthly statements so that our invoices are sent out at the same time patients are receiving their paychecks. This is one of those duh moments. And it actually does beg the question, why do we send out statements each and every month? And the answer is, I don't know. That's just the way we've always done it. And so today, during this webinar, I'm giving you license to change, and with the opportunity to transmit these communications to our patients electronically, right? Sending a notice, a text, a message, a secure message twice a month, well, that doesn't cost you anything more than it would once a month. So let's go for it. Now, what is a good way to transition your patients to some sort of electronic platform? I think this is a really great way to do it. Woohoo! We're going environmentally friendly. We're getting rid of our paper statements. Hey, if you want to continue to receive them, no worries. But we are indeed going to have an administrative fee for that. So this is an example, if you're interested in this idea, to be able to use. Of course, whenever you charge patients anything, and of course, when it's over and above medical services, you want to be sure to consult with an attorney about this policy. Another really great example, I actually got this idea from an allergy and immunology practice. They had a quote unquote invitation. It was a little bit of a stocky envelope, and on the outside envelope, it really did say, "You are invited." And when the patient opened the bill, or better said, when the guarantor opened the envelope, it said, "To pay your bill." Now, as you can see, a few other ideas that I may have is you want to use a little bit different, maybe an acronym of your practice instead of your traditional logo with PO box. Again, a little bit different to kind of get this notification read. Maybe a colored envelope, a real stamp instead of a metered post, wanting to make sure that you have the amount of the balance, and then blame somebody else. Oh, our accountant will simply not allow us to carry your account. This isn't us. This is him or her. This is kind of funny, but make sure you actually have a phone number on there. It's amazing to me how many practices have not a phone number, but maybe even sometimes the wrong one. So call yourself, make sure it's the right one. And please make sure you don't say due within a week. A week from what? You're just letting the patient have an excuse not to pay. Have a due date. And last but not least, send your collection letters from Judy, or if you want a man's name, from George, but please make sure that neither Judy nor George actually represents someone who works at your practice. And the reason I say that is when you get a Judy call, or a George call, or whatever name you want to create, you know that it's top priority. Someone is calling to pay off or to at least make a payment on their bill. And it's an easy way to alert yourself of that. We want to make sure that we engage everyone. There's no longer an opportunity for a team member to say, that's just not my job. In fact, I would almost ban the term business office because it gives a sense of it's not my job, right? It's an office. Go down there, go over there, call that person. We need everyone to be part of the revenue cycle management team. We need to start thinking about our practice employees as the directors of denial prevention, the directors of price transparency, a point of service collections, so that our team really recognizes the importance of their engagement. And of course, we know that every employee, not just the front office, but our nurses, our medical assistants, our physicians, every time I have a physician who says, oh, don't worry about that bill, that simply means a lifetime of non payment. Not only that, but I'm also going to tell 7 of my friends they need to be sure to go see this cardiologist because he or she doesn't charge for their services. So, making sure that every employee is engaged from a revenue cycle management perspective, because the patient doesn't have a lens of it's what it's this office and I can only ask them this question. Patients are recognizing that their financial accountability, that their transparency from a pricing perspective is really it's really their right. It's their right to know. And so we're starting to see patients ask when they call, what is this going to cost me? When they check in, can you tell me how much am I going to owe? If our line for all of those inquiries is go talk to the business office, go talk to the billing people, we're going to be dead in the water. Remember, the landscape is changing. Now, unfortunately, and there's lots of reasons why this exists, but the insurance companies have an economic incentive not to pay us. When you think about it, right? They're collecting all of these monies coming in from premiums, from employees, employers, and they're sitting there with this pot of money. And it's a big pot, right? It's $1 billion for some of these large payers. And think about what that $1 billion is doing in a bank account. They're reinvesting it, etc. And so if I then don't have to pay out when Sally over here goes and sees the orthopedic surgeon, I can continue to invest, reinvest, etc. So there's really an economic incentive built in to the way we do business from a healthcare reimbursement perspective in the US to not get paid or not get paid correctly. We have to have, the monitoring systems in order to really, really be able to maybe not win the battle against the insurance companies, but at least be in the battle. And these data, the American Medical Association historically had published this amazing health insurance report card. Unfortunately, they stopped publishing it a couple of years ago, but it was, I'm pulling up this data from the last report a few years back. It's alarming. Physicians don't get paid correctly. And this is contracted fee schedule. Did at the contract rate, did physicians get paid correctly? And the answer is no. No. And I think some of this has to do with the way we look at payments. So, I mean, let's just take, for example, a typical, level 4 outpatient established office visit, or doing a series of, some lab tests, and as you can see, as your analysis as well. And so it's quite common for us to say, check, check, check. I've gotten paid for 3 of these line items. And I mean, I don't want to say that's good enough, but many of our computer systems are set to, well, that's good enough. And so we write off that your analysis, the 81001, oftentimes is a contractual adjustment. And frankly, we'll never know the better of it. And maybe you might say, well, the payer was never going to pay it in the first place. But if we as healthcare organizations continue to say that, I will tell you that that pot of money, that $1 billion that United Healthcare is investing, is just going to get bigger and bigger and bigger. We have to fight the battles. We simply must. And so we've got to make sure that we have that in process, either automated or manually, ideally, obviously automated, where we are actually looking at the line item level for the allowables by all payers and all of their products into the marketplace that we are dealing with. And are they getting paid correctly? If they're not, we need to take action. This may be on a line item basis, or if we see a trend like all of our 99212s are getting paid incorrectly by Blue Cross Blue Shield, and it may be $2. But when you add up all of your level 2 visits over the year, the $2 is actually a fair amount of money. And so we also, of course, want to make sure that if we just get denied flat out, or if there's no communication whatsoever, that we have a plan in place to manage our receivables, And a couple of tips about this. Many of you are amazing already, but let's make sure that we both have our what I like to call correspondence. So like the paper that's coming in to our revenue cycle management team, that might be, a notification, a letter that says, we've sent this patient, a notification that the service was experimental. So it's not actually coming in on our remits, but the denial is coming in on paper via this correspondence. And even in 2021, right, where we should be seeing no paper, we still have paper coming in. What we need to make sure is those get routed into the same place for us to be working receivables. So we also, of course, need to make sure that we start thinking about, okay, well, who's going to get that, right? This experimental service, maybe it was Humana that sent this communication. So like, who works that? We're fools if we think that the patient is going to work that. The patient's not going to work that, right? We've got to have in place a process so that all of these non payments or non communications, if I haven't heard anything about this service, that I need to have a work plan, a queue set up so that I know who's going to be accountable to work it, what he or she should be doing, and when. And, there's some basic things like let's make sure that if I've got 2 hours to work receivables, that I'm not working by alpha. I am working by highest dollar first. Now, I know, and because I've been on Amazon, Barnes and Noble, Borders, Books a Million. I've looked for the book of common sense because there's a lot of people who work in revenue cycle management that I'd like to give it to, but it doesn't exist. So I need you as the executive, as a leader, to really think about this very astutely because, as you know, this is a battle. So I've got to have everything in my arsenal ready to go. Now, I like to organize my teams based on payer because there's so many nuances related to payers. Now, there's some exceptions, of course. We have some specialties like anesthesiology that may need a more specialty lens. But of course, within anesthesiology is a single specialty practice, although you may want to carve out pain. We do know that a payer based process is a really amazing one, a way to go because there's so many nuances related to follow up. Regardless of how you organize, making sure that your team is creating notes and not just notes that they can read. I love like Biller's shorthand, and I'm like, what does that even mean? So making sure that if you're using shorthand, and I know this sounds really crazy, and again, it would be in the book of common sense, but it doesn't do any good whatsoever if you have a note and no one else can understand it. So have the shorthand for everyone working in revenue cycle management. Now, let's also, of course, making sure that we're monitoring our performance. These are just high level KPIs, key performance indicators, and I generally find that they really, really vary. And that includes popping over that expected range by payer. So if I, for example, have way more Medicare, then my KPIs are going to look really good. My cash flow may not be the best, but my revenue cycle management indicators are pretty good because Medicare is a clean payer. They're black and white. They pay, they don't deny a lot. They pay according to fee schedule, et cetera, et cetera. Once I start moving into my Medicaid managed care organizations, once I start moving into workers' comp, all bets are off. I can't have the same KPIs that I would if I was running an all Medicare practice, unless, of course, that's all Medicare Advantage, which, as you know better than me, is actually really a commercial product. It's not really Medicare. It's just called that because our managed care MCOs or managed care advantage plans, they're just as crazy as any commercial payer in terms of getting payment. Making sure we have that arsenal. So, how do we do it? Here's some additional best practices for you to consider. I really think that instead of kind of beating the revenue cycle drum, which we have for many, many years, as revenue cycle management professionals, let's change the optics about this discussion and work with our practice, work with our organization, work with our doctors and advanced practice providers that this is about patient and family experience. And it really is. When you start to unpack all of what we've just discussed is patients don't want mistakes either. They don't want to be getting these crazy bills and seeing this a year later. So, if we frame these changes from a patient experience perspective, it's a game changer. Making sure that we have incentives for our team, and that may include giving an hour off, leaving an hour early, remaining working from home. Maybe it's 1 or 2 days a week, wearing jeans for a day, etc. And I love this third idea, a certification process, because we want to really think about what we can do, frankly, at no cost. And so if we can create just some basic skills test, this gives our employees a really nice feather in their cap that they can put on their resume that they've been certified, for example, in, I don't know, reading a remittance or working a denial. And you might say, well, what? Well, yeah, I mean, you can create some sort of certification and have your employee or employees run through that. Introducing a new title. So maybe you've had like these billing reps or billers or, oh my gosh, please say no, the girls for many, many years. And it's time. It's free to have a new title. So now they're the billing specialists. And speaking of HR, maybe create a professional pathway so that you can really keep your greatest team members. And an easy way to think about that is to create a path, a professional path between the front office and the business office. Now, we've run through hopefully a really big host of ideas for you to consider. And now I'd like to turn the platform back over to Jonathan for our Q&A period. Jonathan?
Thanks, Elizabeth. A lot of those observations and stories are definitely relatable. And as business office folks, I think you brought a smile to many of our faces with a lot of the things you pointed out. So we'll go ahead and open it up to Q&A for Elizabeth. All right, for our first question that came in for Elizabeth, will we be able to deliver care via telemedicine in the future and continue to be paid for it?
Oh gosh, Jonathan, that is like the question of the day right now. As we discussed, the public health emergency is now extending into July. However, the federal government has at least given us a signal that they will extend that through the end of the year. And what we do hope is that during that time period, there will be an opportunity for not only the federal government, but also the state governments. And Jonathan, we have to throw the insurance companies in too. So this is a pretty big number of stakeholders to come together and to really figure out how to make this work. So I certainly have hope, but as you know, it's already June, so we're looking at T minus a few weeks right now. Hopefully that'll get extended. Then it'll be a few months. But you know what? Americans want this. And so I think that's going to be hopefully a lasting positive impact of the pandemic. But there are a few kinks to work out in the system first. Jonathan?
Absolutely, that makes sense. Our next question, we're having a hard time recruiting new billers. Any suggestions to help us?
I mean, again, I guess I'm not surprised by this question either, because this seems to be the number 2 question of the day. But seriously, we cannot find team members. And I think it is really important for us to maybe think outside the box a little bit, because historically, particularly in revenue cycle management, we kind of don't ever want somebody who's never done it before. But given the labor market, we may have to rethink that strategy. So, what are some tips? Certainly, always be on the lookout for great people, even if you don't have an open position. Because if you don't today, I'm almost going to guarantee that you will a month from now. So, keep your radar out all the time. If you have had a team member who maybe has gone home because of childcare or some other issues, is that an opportunity to recruit them back, but maybe not on a full-time basis? And in fact, that's a really good way to save money, because you quite often don't have to spend as much on benefits as well. And then we don't necessarily have to have a biller in order to hire a biller position. So maybe we could think about a bookkeeper in the retail setting or a hospitality industry that we could really train in order to do this job and do this job well. And then last but not least, become a site for an externship program. This is a great way, because we have more and more technical colleges, community colleges who are producing team members for the healthcare setting. And so you insert yourself right into that pipeline by becoming an extern site for those for that program. And then you get to choose the best of the best. Jonathan?
Absolutely. We have time for one more question. So we've seen a spike in denials recently over the past few months. Have you observed other practices also experiencing this trend?
Jonathan, I was just talking to an orthopedic practice this morning about this very issue here in the state of Georgia. And so, first, let me say is that you are definitely a practice to our audience member that is experiencing a very consistent phenomenon. And I don't know if it has to do with the dynamics in terms of claims payment from the pandemic, where there weren't a lot of claims being paid out because, obviously we didn't have as many services. And then the payers were being a little bit nicer because, right, they weren't having to pay monies out. I don't know if it has to do with that. And honestly, I don't have the lens into the insurance companies to be able to confirm that. But whatever it is, we are seeing an increase across the board in denials from our insurance companies. And so it's all the more reason to be incredibly vigilant with this real battle that you have to take on each and every day. Jonathan?
That's some good information. Thank you, Elizabeth. We really appreciate you being here today as our guest speaker, and we'll let Lori take us out and conclude the session.
Great. Thank you again to Elizabeth and to our attendees for your time and participation. If you have any questions or would like more information, you can visit our website at www.nextgen.com. Thank you and have a great day.